are the team of Immaculate Dissection. We're so excited to introduce you to Immaculate Dissection concepts. We're going to pull in a little bit of information from core concepts, lower extremity and upper extremity concepts, our first 3 segments of our seminar series. So we're super glad to have you here today. My name is Dr. Kathy Dooley. I'm one of the co-founders of Immaculate Dissection and one of your lead instructors. I am a chiropractor, chiropractic rehabilitation specialist, movement specialist, if you will, and also a gross anatomist. I spend half of my day dissecting human and the other half of the day teaching you how to move. That's part of the reason why this seminar exists, because of the dissection being brought into real life. Now, Dr. Anna Folkmer, you are an amazing co-founder. Would you like to talk about yourself?
Hi, thank you all for being here. My name is Dr. Anna Folkmer. I am a licensed acupuncturist and board-certified herbalist practicing here in Midtown Manhattan. I have a background as a classically trained dancer, so my favorite thing in the world is the marriage of art and science and what we can do with that information. I love bringing the anatomy to life with movement. I love finding parallels with acupuncture points and functional anatomy, and that realization of how many times we're all talking about the same thing using a different vernacular. So that's what I can try to contribute to this whole operation. And I'm just really excited that you guys are all here tonight. So thank you.
Because she probably won't brag about herself, she's an incredible mover, a trained dancer. She'll blow your mind, and also the most brilliant clinician, amazing clinician. All right, so I'm going to brag about you now. Okay. Danny Quirk, if you guys take a look at your manuals for a second, all the artwork in here is original from Danny. And a lot of these are based on his paintings of the body. If you look there, this is actual painting on the body.
They're photographs of paintings.
Photographs
on the
of
body.
painting. She's that phenomenal. Yes. Okay, sorry. Danny.
Hey everyone, as Kathy said, my name is Danny. I'm a medical illustrator and formed a somewhat specialized niche in doing these realistic body paintings. It's a way in an attempt to basically bring the textbook to life by painting the structures directly on the body. The viewers have the benefit of seeing how the body moves and how the body works, working as an in-between between an actual person and cadaver. So you can see the structures on the body, you can see how they move, and get an understanding of our inner workings. I had met Kathy and Anna in a gross anatomy class. Painting up Anna in the class there, students were really able to cross-reference the painting with the textbook and just really heighten their level of learning from there.
I want to piggyback on that, because not only did Danny and Anna migrate to the course that I taught to be able to dissect for themselves, Danny is painting on Anna, and the students, my doctorate of physical therapy students, left their dissections to come to watch the anatomy move on Anna that Danny had painted. And that's when Immaculate Dissection was born. That's when we knew we had something, that not everybody gets the opportunity for human dissection. And that's a bummer, to be frank. But that's okay, because even the people that were honored to do so left their dissections to come see it move. Because one thing the cadaver doesn't do is move. Hopefully not. And it's embalmed, and things don't move as freely, even when you can get things to move. And to be able to watch it in layers like Danny paints and the way that Anna moves, we can see an idealization of the way things actually move on our patients and clients. So this is the way that we formulated Immaculate Dissection and brought it to life for you. So don't feel like you missed out too much if you haven't done human dissection. It's all right. It's okay. It is a big part of my life, but you know what? This is amazing. And we really want you to learn anatomy in this way. Who has learned anatomy before? Who's had anatomy instruction? Almost everybody here. Okay. So if we throw bombs at you and ask you origin, insertion, innervation, blood supply of external abdominal oblique, internal abdominal oblique, serratus anterior, and iliacus, are you ready for the quiz? What's wrong, do you think, with anatomy instruction? What do you guys think? Why can't you remember that stuff? It's not alive. Why else? I like that answer. Why else? A book is two-dimensional. What about all this fancy 3D imaging that we have, like with apps? What's missing with that? You can't feel it in your body. I love that, Monica. That's such a huge deal. We have to be able to feel things and move things, feel things for ourselves, for us to own them. So what we're going to learn today is the anatomy of external abdominal oblique, internal abdominal oblique, two very important core muscles. We're going to move into the upper extremity with serratus anterior, and then go into the lower extremity with iliacus. And not only are we going to blast you with origin, insertion, innervation, blood supply, action, right, that you're used to, but we're going to make you feel this for yourself, palpate for yourself, move for yourself. If your neighbor will let you palpate them, then palpate them, okay? Now, we want to make sure that you bring this to life for yourself, like Boris said. It's alive. Bring it into your own body. Don't let anatomy scare you. The reason why I became an anatomist is because anatomy really scared me. I took a seminar where we had to do a lot of movement, and I was like, this is too much anatomy. And then most people, they just freak out and then abandon it, feeling they're not smart enough, they're not good enough, this is too dense. All the reasons why people give up on something. You are not any of those things. If I can learn anatomy, you guys can. I can tell you what, these two people next to me know anatomy backwards and forwards, and they do not have an anatomy degree. You do not need to have that. We're about to prove it to you, okay? So are you guys ready to get started? Are you excited? Yes, me too. All right, great.
So to get started, I'm going to introduce you to Dr. Jake Altman, who is a brilliant chiropractor and has offered his long lean modeling services for us to have a good visual of what internal abdominal oblique really looks like and what it looks like in motion. Jake, if you want to just start by showing us here. All right. So we're going to get started with internal abdominal oblique. You're going to notice some of the insertion sites. We have the linea alba here on the anterior abdomen, which is your bloodless plane. We're going to have all the way here, rib 10, so pretty far down, actually, down on the costal margin, all the way down to rib 10, much lower than a lot of people think. We're going to have all the way down here into the pecten pubis via the conjoint tendon, which I'll talk about in a minute. But it's really important to just kind of start getting a visual of where everything is attaching. We actually have it reach all the way to the iliac crest and even towards the back. Your IAO, if we're okay with IAO for internal abdominal oblique, exists in your back. That's kind of huge because as a clinician, a lot of times you hear people come in, oh, my QL, everything's QL. It's not always QL. It actually can be IAO or other structures in the back. Another important feature of the fact that this exists on the back is that it attaches to the anterior layer of the thoracolumbar fascia, or the deep layer of the thoracolumbar fascia, whichever one you're more comfortable with. This is hugely important. This makes this muscle an intrinsic core stability muscle. One of the rules of intrinsic stability is that you have to be able to attach to the anterior layer of the thoracolumbar fascia, and IAO does. IAO exists in synergy with transversus abdominis, with TVA. They are BFFs. They are best friends. In fact, they have a neuromuscular bundle in between the two so that if something becomes compromised, it'll actually cut its own blood and nerve supply off just to keep it in check. So they're really, really, really existing there synergistically. Now, the importance of IAO attaching all the way to the iliac crest and down into the pubis is the fact that this is where we're going to receive force transfer into the hip and into the lower extremity. So we have force generation here in the abdomen that's going to be transmitted through the hip into the lower extremity for power. So we're going to stabilize and then we're going to ambulate. When you go into an inhale, the diaphragm is going to drop and these muscles are going to eccentrically load. So they're going to really, really, really take a nice long position. This is pulling your rubber band back so that it can fire into the lower extremity or wherever we're generating force at that point. You have to load the rubber band before you can explode it. You have to pull it back before you can generate force. With a nice inhale, you're going to see an eccentric load. Good. And an exhale. There you go. So you're seeing some of its short and long positions with the breath, which is extremely important for breath cueing and the movement of the lateral sides of the body, the lower extremity. And because this is ranked so high on the hierarchy of, our system of checks and balances in the body, we know that we need to really look to some of these muscles first whenever there's dysfunction. This muscle, in its actions, are going to be lateral flexion, a little bit of flexion, and ipsilateral rotation, same side rotation. And you can see here how short IAO has become. So in its long position, we're going to go into lateral flexion of the other side, extension, and a little bit of contralateral rotation. There you go. You can actually put your right foot back. There you go. Nice long fibers here. Come back to short position. So, yeah, you can keep your right leg back. Perfect. And rotation, a little bit of flexion. Good. And cue it with an exhale. Now watch what this does. Even shorter. That exhale is going to give you even more of a concentric load, okay? And then go into lateral flexion on the other side, contralateral rotation, extension. And I want you to cue with an inhale. Even more of an eccentric load. That inhale, remember, helps this eccentrically load. Okay, you can come back to relax. Thank you. What do you think would be problematic if someone can't enter an eccentric load? What would happen if they can't fully reach that long position for IAO? What kind of problems could come up? You're going to have a problem powering force transfer. If you're existing in this state of sort of semi-contraction, then you're never actually really powering anything because it's sort of just being. You might see this in people with issues with rotation, with a breathing assessment, which we do a lot of in immaculate dissection core concepts, level 1. You'll see that they have trouble filling here. That inability to fill is proof that they're having some trouble with their eccentric load. Now, I had mentioned this structure called the conjoint tendon. The conjoint tendon is where IAO and TVA conjoin to attach down to the pubis. This conjoint tendon is often cut in a lot of abdominal scarring, cesarean sections, any kind of invasive surgery to the abdomen. What do you think that would do to their eccentric fill? If this is now offline or it's miscued from scarring, perhaps, do you think that they'd be able to fully reach eccentric load? No. So why is that problematic? If you can't fully eccentrically load something, you're going to have issues with power. Your intra-abdominal pressure has been lost. You have areas, it's being robbed. It's not filling right here. That's going to show up in a bunch of different ways. Our bodies are really, really intelligent networks of patterns. And if we lose intra-abdominal pressure and we lose stability, we'll find it somewhere else, although it might not be in a way that best serves us. You often see people with cesarean sections. We know that women often experience incontinence afterwards, bilateral hip pain. This is because the conjoint tendon's connection to the pecten pubis is receiving force transfer from the abdomen, and this is helping the pelvic diaphragm or the pelvic floor receive its cueing. So you're going to have a miscueing to the pelvic floor if this is disrupted. I can't stand up here and talk about IAO without mentioning a couple of major acupuncture points. That's what I do. That's what I love. So we have a couple of points here. We have liver 13. We have gallbladder 26. You'll notice these are right in the fibers, right here between rib 10 and the iliac crest. At the very least, acupuncture is offering proprioceptive cues. If you take somebody through a breathing assessment and they can't fill here and they have no lateral expansion, they have no lower abdominal expansion, cueing that part of the abdomen is going to help bring it back online. What's fascinating about acupuncture is the functions and the indications written for these points thousands and thousands of years ago, preceding human dissection, is calling for inability to rotate the trunk, which we know IAO is an ipsilateral rotator. Even lumbar pain, low back pain, rib side distension, that's a big one. Pain here along the costal margin. So we have these points laid out a very, very long time ago, and we have the functional anatomy here to prove it. We know that this is why this works. If this is receiving improper cueing from movement, from breath, then it will often manifest. Remember, we're really, really smart. Our bodies are going to get the job done. We're very efficient. We're in New York City. We're going to get things done. But it might be that we also experience incontinence, trouble rotating, rib side distension, lower back pain, and all of the above. And that's going to be when these points would be indicated to be used as well. IAO is receiving a lot of its innervation from the thoracolumbar nerves. So you can imagine that if Dr. Altman here, he's a chiropractor, so I'm sure his thoracolumbar mobility is excellent. But if he did have some hypomobility of his thoracic spine, it's going to shut down some innervation. It's going to really cause some misfiring to the IAO. And so it's not going to be able to get its proper cueing. We're going to experience, some lag there as well. Even more reason to check how well are your patients moving. So some of the abdominal scarring here, in addition to cutting through the conjoint tendon, it's actually cutting through the epineuritis of IAO, of TVA. This isn't a doom and gloom talk, right? If there is a scar here, it's okay. This is information. Information is just information. There's no need to judge it. We can do something about it. We can do scar therapy. We can really work some of these areas. We can release them with multiple release techniques, whichever one you choose to use. And that's going to really help bring some of these areas kind of back online and help him get his full range of motion in a concentric and an eccentric state.
Dr. Anna's talking about the conjoint tendon, the joint tendon between transversus abdominis and internal abdominal oblique. That area where they're connecting is also connected to the iliopsoas fascia. Not the iliacus muscle, not the psoas muscle, but the iliopsoas fascia, the fascia that covers those two muscles superficially. Now, this takes the intrinsic force that you build and takes it to the lower extremity. What do you guys think happens in cases where Dr. Anna is talking about where there's a lack of extensibility in the internal abdominal oblique, therefore a lack of extensibility at the conjoint tendon? What do you think happens with iliacus and psoas? They compensate. Mm-hmm. And so this is why some of your clients or patients, when they're in a supine position or have to lift their leg, they get that pinching sensation in their hip. We'll talk more about that when we get to iliacus, but don't forget that if someone has pinchy hip pain, is the first place you look the hip? It better not be. The first place you better look is internal abdominal oblique. So please don't forget what Dr. Anna is very eloquently telling you about this beautiful anatomy, that you cannot always go by a pain response. You have to know your basic rules of biomechanics and your basic rules of anatomy, that internal abdominal oblique and transversus abdominis have a joint tendon that attaches to the pectineal crest, but also comes down and inserts onto the iliopsoas fascia to take that force to the outside world. That's why people get that pinching pain down there. So don't forget that. When you feel it in yourself, like in a squat, who's had that before? Ouch, ouch, right? Especially if it happens bilaterally. The problem is not the hip. The problem's up top. Any questions to fire away at before we move on? You guys want to watch him move again? Yeah. Maybe you guys should feel this. Do you guys want to feel it?
Yes. Do it.
Maybe the folks in the periphery. Stand up. Feel it for yourself. How about everybody right leg back?
Yeah.
Like Dr. Jake?
Yep.
Okay.
So everybody have your right leg back, and you'll be able to feel, remember, where's this attaching? You're going to feel a lot at rib 10. People will bind up here a lot too. I mean, if you're ever palpating one of your clients or palpating one of your patients, it will often be really, really tender here. So to get to its short position, we're going to go into lateral flexion. We're going to go into a little bit of flexion and ipsilateral rotation. And the last step is what? Cue it with a what? Exhale, good. If you feel that under your fingers, you feel the way that shortens up.
Speaking of binding.
Yes, ma'am. Okay, so we're going to take it to its longer position. We're going to lateral flex to the opposite side, go into a little bit of extension, and contralateral rotation. You can actually reach that same arm up just for maximum eccentric load. And take a nice inhale. Really feel the way that that expands into your hand. Good. Okay, and then let's just bring it back to its short position. To exhale. Awesome. Did you guys feel that move? Did you feel the fibers shorten and lengthen underneath your fingers? That's amazing. That is your force transfer. That is your power generation. Maybe we won't have to do it in here because there's a lot of bodies in the space, but you may want to check a discrepancy between the right and left side. And think about, do you have hip issues on one side? Remember what Dr. Julie was saying about the iliopsoas fascia. Do you have a history of hip compression? Do you have a history of any sort of things that could be related to the force transfer into your lower extremity? And notice how your fill changes from the right and left side. And you can kind of match that clinically with your symptoms.
All right, if you guys could turn in your manuals to page 22, take a good look at the external abdominal oblique. Do you guys feel educated on the internal abdominal oblique now?
Yes.
Yeah. Incredible muscle, often overlooked. Man, TVA gets a lot of credit, right? But don't forget about his best friend, the internal abdominal oblique. So the external abdominal oblique is a lot different than the internal abdominal oblique. Look at its anatomy for a second. Okay, we'll also look on Dr. Jake. Dr. Jake, do you mind doing a catty corner turn towards me? So the majority of people, maybe put your arm a little back so people can see the difference. Can you right away see a difference here laterally? How high up does it go? High up. People think their obliques are here, right? External abdominal oblique goes all the way up to your fifth rib. Now we're probably kind of wondering where that is, right? I got a cheat sheet here, but if you don't have the cheat, it's a little tougher, right? 1, 2, 3, 4, 5. For most of you guys without breast tissue, it's right below your nipple line. You can see on Dr. Jake, it's right below his nipple line, okay? Rib 5 can also be palpated from the front. If the first palpable rib is rib 2, right? So come to your clavicle, come down, you can run right into rib 2. Then the next one down is rib 3. Next one down is rib 4. Next one down is rib 5. And then trace yourself around obliquely. Anybody tender there? Holy shnikes! Rib 5 is a really tender spot. The spot you don't know is tender until somebody touches it. Not a lot of people complain about this fifth rib pain unless things are really, really bad. Okay? The external abdominal oblique here is very close to an acupuncture point too, Dr. Anna, right? Mm-hmm. Pretty close to spleen 21 here, major stress point, and you'll find out why here in a second. So this muscle goes from rib 5 down the rib cage, right? Coming over to the costal margin, going all the way down to the iliac crest. So put your hands right above your iliac crest so you can feel that. You can see it on Dr. Jake. Coming down to the iliac crest. And now he's going to take his fibers from the ASIS, the anterior superior iliac spine, that big bump everybody calls their hip, right? And it comes down to become tendinous or aponeurotic, a fancy word for broad flat tendon. And it comes across the abdomen to come into the linea alba, go all the way down to your pubic tubercle. Now, we all got to investigate this for ourselves because your neighbor might not want that. So what you want to do is find your ASIS with your thumb. Okay, so find that with your thumb, that big bump on your hip, anterior superior iliac spine. And I want you to take your index finger and then point it straight downwards towards your zipper, if you got one. And you'll feel a nice little bump there. Do you guys feel the bump? Now, the guys might have a little bit of trouble feeling that because they got a spermatic cord covering theirs, but we females can feel ours pretty readily. That's called the pubic tubercle. So if we look at it here, can you guys see? Put my fingers on the ASIS, put my fingers down, I fall onto this pubic tubercle. This tubercle is created by the pull of external abdominal oblique and his best friend rectus abdominis, two extrinsic core muscles. Now, I didn't mention anything about this muscle attaching to the deep layers of thoracolumbar fascia. Dr. Anna mentioned internal abdominal oblique and transversus abdominis attaching to that, right? Never do I say the external does that because it does not. It is an extrinsic core muscle, not intrinsic. Well, what did Dr. Anna tell you was the difference between an extrinsic core muscle and an intrinsic core muscle? What is the difference? Because that's a hot button topic, this core stuff, right? Intrinsic muscles help you to build intra-abdominal pressure the best, right? But they're more tonic than phasic, meaning they tend towards being more stability muscles than permitting a lot of mobility. But the external abdominal oblique has the word external in him because he's extrinsic, meaning he doesn't help you build this force as well, but he does help you take the force you build and send it to the outside world. And the way he does that is via his attachments. So remember the ASI, pubic tubercle? You found that area? There's a ligament there. Do you guys know the ligament that runs there? Anybody know it offhand? Remember from anatomy class? Oh, they're so good. The inguinal ligament. So this area is called the inguinal region, right? The inguinal ligament. And a lot of people, if you like beautiful, sexy anatomy, it's that little cut that people make right here, right? Everybody loves that little cut. We don't know why that's appealing. It just is. It looks like it's going somewhere naughty, right? The inguinal ligament is created by a double layer of the external abdominal oblique aponeurosis, and it serves as a partial attachment site for various musculature, right? And also, it's a limitation and a creation for a canal. It's the anterior wall, the inguinal canal, that allows passage for really important structures like the spermatic cord we talked about, and the ilioinguinal nerve, a nerve that helps us, if you're a dude, feel your scrotum in the front. If you're a girl, feel your labia. You may not think that's important until something gets torqued in there and you feel that little zinger in there. I've had so many guys come to me as a clinician saying, Julie, you're the only one I can trust with this, okay? Whenever I move, I got a little thing shooting down to my testicle. It's freaking me out. Should I get surgery? I go, wait a second. We got to see if the obliques are twisting up that nerve. They get big sighs of relief when after a couple of treatments, that stuff's gone. They're like, okay, no cutting into my scrotum today. Fantastic. So you can understand that these weird symptoms, well, how would you know if they probably are getting ultrasounds? They're probably thinking it's pretty serious. When you know your anatomy, though, it doesn't freak you out as much because the external abdominal oblique is forming part of that wall and creating a possible tension on that nerve. In a female that's pregnant, anybody ever worked with pregnant people? One of my favorite populations, not only because they're giving birth to, a massive thing, watermelon out the size of a lemon, right? But also because they experience a lot of anatomy change in this region, and it's really, really tough for them if they have round ligament pain. You guys heard of the round ligament of the uterus? It's this ligament that runs through that canal. It circles around. They complain of this pain. They do this. They're like, I got back pain, and this pain here that's freaking me out. And it's just the round ligament. Just like the guys were freaked out by the ilioinguinal nerve, the ladies are freaked out by round ligament pain, and a lot of it's caused by external abdominal oblique. So if you understand how the obliques work and help them build good pressure and also build them good force transfer, a lot of these discomforts go away, and you become quite a valuable clinician to your patient, or a great trainer, great massage therapist, great yoga instructor for knowing this stuff. If you can really put them at ease, it helps. Knowing the anatomy matters. External abdominal oblique doesn't get to be an intrinsic core muscle. That's all right. He doesn't want to anyway. He's too busy trying to be phasic for you. He wants to move it, move it. The external abdominal oblique is expanse. Look at Dr. Jake here. It's going all the way up to rib 5, coming all the way down to the iliac crest. Now, Dr. Jake, can you raise your left hand? Okay. And now do a little spin turn, a little bit of rotisserie. And can we see how far back this goes? Does it go back as far as the internal abdominal oblique? No, right? Internal abdominal oblique goes all the way back to those deep layers of fascia. But the external abdominal oblique stops short. I want you guys to feel this for yourself, okay? Put your hands on your hips and then come right around that iliac crest to the very top, that lateral aspect. Anybody feel a little tender spot there? That's where the external abdominal oblique is inserting onto the iliac crest and ending his domain posteriorly. So the external abdominal oblique, where a lot of people call this QL2, just like Dr. Anna said, this is not QL. The external abdominal oblique function goes all the way back to the posterior. So this muscle back here creates a nice little triangle with the latissimus dorsi, a triangle called the lumbar triangle. As we move over to the front, it's helping us form a wall of the inguinal canal, and it comes over across the rectus to form the anterior rectus sheath. We talk a lot about this in ID1, the rectus sheaths and their importance for force transfer. But this external abdominal oblique is the only muscle that gets to be present for the expanse of this rectus sheath. Do you see this aponeurosis here? This is created by external abdominal oblique, and just deep to that is your rectus abdominis. So everybody put your fingers right here. And now give me a little cough. Don't cough on your neighbor. You guys can feel like rectus, right? Rectus abdominis is fortified by the intrinsic muscles and the external abdominal oblique via the sheath. So the external abdominal oblique gets to really, really shine as it helps to form this anterior sheath from rib 5 all the way down to the pubis, to the pubic tubercle. Really important muscle. Now look at this. The external abdominal oblique doesn't just have a relationship with latissimus dorsi in the back. It has a major interdigitation. On its lateral insertion here, look at this. Take a side view of Dr. Jake here. What is this muscle that's interlocking with this at ribs 5 to 9? Serratus anterior, hot button muscle. Dr. Anna will tell you it's the most important muscle of the entire shoulder girdle. Lat, sorry, it's not your day. Serratus anterior is the one. And this is why. Serratus anterior from ribs 5 to 9 interdigitates with the external abdominal oblique. Now, why, oh, why would it do that? Why would the external abdominal oblique and the serratus interdigitate at 5 different ribs?
Transfer core to the shoulder.
Oh, Boris, to help transfer core extrinsics to the shoulder girdle, to the most important muscle of the shoulder. Now, EAO has connections to pec major, I'll give you that, but not like this. My students have such a hard time in the lab differentiating those two. It's so tough. Has anyone had the honor of dissecting this in the lab? That's all right if you haven't. You haven't missed much because you can't get them apart. I have to take my scalpel and magically around there and circle those ribs, and the students are like, how did you see that? That did not exist before you came over. And I said, yeah, it does, but they're so interlinked for very good reason. You want this interdigitation because it helps you with force transfer. So let me ask you a question. If you're treating somebody with a scapulothoracic joint problem, like winging scapula is a famous one, right? Nobody likes that. Where do you start? Do you start with serratus anterior? Rookie! Where do you start? Intrinsic core, like Dr. Anna talked about, and then EAO. But if you're starting with the serratus and not able to get that muscle on, it's probably because something's missing centrally. Do not be a rookie. Know your anatomy. Know your hierarchy. Who's number 1 in your hierarchy? Intrinsic core. Who's number 2? Extrinsic core. Then you move into the scapulothoracic joint via serratus, but not before so. The innervation of the external abdominal oblique is going to be again from thoracolumbar nerves, and we're going to receive our feed from a similar place. So again, like Dr. Anna said to you, even though these muscles are expanding all the way down to the iliac crest and into the pubic bone, they are innervated by the lower segments of the thoracic spine. So you better make sure this area from T7 all the way down to L2 is mobile. How many of you guys treat people with thoracic hypomobility? Can they get their core on? Probably not. Not to the most optimal abilities. So make sure that you're always assessing the thoracic movement along with core assessment. You guys want to see this anatomy move? Oh, I do. It's a little bit different than internal abdominal oblique, slightly, right? So Dr. J, can you put your right leg forward and your left leg back? All right, fantastic. Maybe you do a little catty quarter turn towards these guys. Awesome. Can you guys see most of external abdominal oblique? This way a little bit more. I'm going to raise your left arm up the entire time just so they can see this move, okay? And I'm going to assist Dr. Jake. All right, Dr. Jake, I want you to move in the Y planes. We're going to go into lateral flexion, ipsilateral lateral flexion, coronal plane movement. Then we're going to go into not ipsilateral rotation, but contralateral rotation. That's a mind blower with this guy. And then we go into flexion on the x-axis. Not flexion of the spine so much, but flexion at the ribs, right? Good. Feel weird, Jake?
Oh, yeah.
It's bizarro, this feeling. Is he going to inhale and exhale for concentric contraction? He's going to fully exhale. So let out all your air. Good. Now look at that short position. See all that wrinkle? Okay, how are you going to make it long? Help me make it long on the y-axis. We're going to make him Contralaterally, laterally flex. Very good. We're going to make him ipsilaterally rotate. Weird. And then have him extend here at the rib cage. What's his last cue? Inhalation. Look at that stretch. Now watch it shorten as I take him into the next position. Left lateral flexion, contralateral rotation, and flexion. Do you guys see that? Exhale fully. Good. And now let's take him into a long position. Eccentric loading. Fully inhale. Do you guys see the effect on serratus then? Oh man. If external abdominal oblique has lost his extensibility, the person could be stuck in this opposite side rotation. You can relax for a second. When someone has this kind of posturing, which does happen, right? Can you guys see how the external abdominal oblique on Jake's side here could be in a short position, right? So you're going to meet him where he's at, and then you're going to take him where he's not. Meet him where he's at, and take him where he's not. You guys got to do this. It's so weird to do contralateral rotation. So let's stand up, and let's do this with Dr. Jake. Let's all put our left leg back. Okay. You can hike your hip up a little more so the fibers kind of fully shorten, okay? So let's do Y plane, frontal plane action first. Let's go into left lateral flexion. Feel your oblique shorten up? Good. Now let's flex at the rib cage to go into X plane movement. Now here's the mind blower. Go into contralateral rotation. Ooh. Feel your left EAO love? Fully exhale, then you'll really feel it. Now go into right lateral flexion, nice and easy. Go into extension, pull up that rib cage on the left. Go into ipsilateral, left side rotation. Reach the arm up and inhale. Oh, how hard was that? Ooh. If you can't fully inhale in that position, you don't own rotation yet. And that is okay. But if you do that a couple times, you might feel that open up and it be a little, well, there's less suck factor to it. But if you're seeing someone that's stuck in rotation, we call these movements pendulums in ID, and you'll learn all about them when you take an ID course. These movements are really crucial, not only for diagnostics, but for our assessments and treatments of our clients. So understanding this anatomy really, really matters. Just to recap, internal abdominal oblique, is it intrinsic or extrinsic? Internal abdominal oblique. Has the word internal for intrinsic, right? How about external abdominal oblique? Extrinsic. How are they different? I'll take anybody. Oh, I love it, Eric. Eric Bergman, everybody. Takes one for the team. The external abdominal oblique does not attach to the deep layer of thoracolumbar fascia, making him extrinsic. Now, is that a bad day for him? No. He's not really concerned with all that. He's longer. He's got bigger attachments. His concern is to move you. Whereas internal abdominal oblique's bigger concern is to build force for you. Now, can the internal abdominal oblique act as an extrinsic core muscle? You betcha. He's the only muscle of your entire body that's both intrinsic and extrinsic. But external abdominal oblique, he's all extrinsic. Do you feel like you got a pretty good understanding of those? And you see how when we put you in short and long positions, the only difference was contralateral rotation. The other planes, they're synergistic, and in breathing, they're synergistic. But knowing that big difference on the Z-axis is the make or break point of you being pretty good at knowing what the patient needs or the client needs. Capiche?
The best place to pick up after EAO is going to obviously be serratus, because what did we learn about serratus anterior? It interdigitates with EAO. Serratus anterior is arguably one of the most important muscles of the shoulder, which is why in immaculate dissection 3, upper extremity, it is the first muscle that we start with. We are really just setting the stage with this one. This reaches out. It starts at the medial border of the scapula on the vertebral bodies, and it reaches all the way to ribs 1 through 9. That's massive. You do not have another shoulder muscle that reaches from ribs 1 to 9. It's going to reach actually on the exterior surfaces, lateral surfaces of the ribs. This muscle actually started in the neck, C5 through C7, and migrated down to the lateral sides of the thorax. It's innervated by the long thoracic nerve. And it's actually innervated on its superficial side, which is really cool. It's kind of a special feature of this muscle because it's really susceptible to palsy. So if I were to karate chop Jake, which I wouldn't, because I love him, if Jake were to take a blow here, it could actually induce scapular winging like that. We talked about abdominal scarring with cesarean sections and things like that. You could see how scars from thoracostomies, someone maybe had some sort of pneumothorax or something like that, mastectomy, lymph chain removal. A lot of this scarring here on the lateral sides of the thorax, occasionally you can have something where it will nick the long thoracic nerve, and now you have improper firing to this muscle. It's going to interdigitate with external abdominal oblique at ribs 5 through 9. And this is going to be force transfer, just as Dr. Julie was saying earlier. This is a direct sort of communication with the shoulder. Where's a good place to start if one of your patients or one of your clients is coming in and they have shoulder issues, have shoulder pain? What's the first thing you think maybe you should check on them? Check external abdominal oblique, but preceding that, let's look at their breath. Let's look at how external abdominal oblique is even filling. Because if it's not filling, how is it sending any information to serratus? Serratus anterior is really important for stabilization of the shoulder. It's going to have a lot of movement on the Y plane and the Z plane, not so much on the X plane. First, let's talk about the planes of movement on the shoulder, okay? Everybody hold your hands like this, okay?
Okay.
So for X-plane movement, we're going to have elevation and depression, okay? For Y-plane movement, we're going to have protraction and retraction, abduction and adduction, but since we're talking about the scapula, we're going to use protraction and retraction, okay? Now imagine that your pinkies are your glenoid fossa. We're going to take it into upward rotation and downward rotation. These are the movements of your scapula. The scapula is a protractor, okay? It's really active in the Y plane. What's really cool is that in the Z plane, it can do both movements. This is an upward rotation and downward rotation muscle. Only muscle in the whole body that can upwardly and downwardly rotate your scapula. So kudos to serratus anterior for that. We have limited X-plane mobility, but in Z-plane, we have the ability to do both. Have you ever had a patient or a client who's, let's say they're a runner, and they have neck and back pain? So imagine I finish running, and I stop, just like this. What have I just done to my scapula? I've completely changed my punctum fixum, my fixed point. And so now I'm asking my serratus anterior to help me breathe. I'm seeking stability here. I'm changing the amount of movement that my scapula has, and I'm asking serratus to do a job that it's not really supposed to do, and it's going to rob stability in other places. So when you see somebody do this, save their neck and their back. Save them, because he who moves first moves the most. So if you've got a lot of movement on the X plane for serratus anterior, you are probably missing out on the party in the Y and Z plane. Serratus anterior is going to be fed by the lateral thoracic arteries and the thoracodorsal arteries. Like I said, we're going to have the innervations on the superficial side. So we want to keep this area away from any sort of blunt trauma, because that's also going to impair its ability to move. It's going to throw off some of its cueing. So I want everybody to watch here. Jake's going to show us his protraction and retraction. So Jake, if you actually can just go into protraction for me. So if serratus anterior is a protractor, what position are we in here? What just happened to these muscle fibers? They shortened, okay? Jake, can you come into retraction? Nice. What position is serratus in? It's in a long position. Notice his scapula here. If he's in a neutral position and his scapula were winging, let's say we were doing an assessment on him and we were checking to see his scapular-thoracic articulation, and he had a winged scapula. What's up with serratus at that point? What's its deal? What's it doing? It's going to be sort of probably stuck in a long position, right? We want to check its ability to enter its concentric and eccentric phases. Do you think that a shoulder problem, a scapular-thoracic disarticulation, if you will, do you think that that would ever precede core instability? You got to check that first, right? Especially if it's on both sides. If both of Jake's scapulas were winging, we got to check out and see what his core is doing. We got to see what kind of force transfer he's receiving from his abdomen. Serratus anterior can often be inhibited on the X and Y plane by what muscles? What do you think might really jump the gun and help with elevation of the scapula? Levator scapula. Yeah. What about with protraction and retraction?
Minor.
Pec minor. Yeah. So these are going to be common relationships that we really have to check. We got to keep an eye on everybody, make sure they're getting along, make sure nobody's jumping the gun on anything, and we got to see what's helping Jake reach protraction and retraction and elevation and depression of the scapula. One thing that I want to mention about the upward and downward rotation of the scapula, how is it possible that this muscle allows the scapula to reach both of those positions? How is it able to upwardly and downwardly rotate? Depends on the fibers. You got it. So the lower fibers are actually going to help with upward rotation. And the upper fibers are going to help with downward rotation. So there's going to be a force coupling that actually happens with the upper and lower traps as well to help the scapula really sort of fall into its place. And this is the way that we're going to see a muscle that's able to do both on the same plane. This is excellent on the Z plane, but only if it's not being asked to do something that it doesn't want to do. Why would you use your serratus to help you breathe? You have this beautiful intrinsic system. You have this gorgeous diaphragm that's hanging out in there, and it's dropping down, and it's helping your abdomen fill, and it's building you force to send out to the extremities. What's going on if we start using serratus? We don't have access to all of that, and it will show up in the body. It will show up as dysfunctions. Again, I have to mention a couple of acupuncture points. So, Jake, if you want to just turn to the side, we have a lot of points here that are really great for musculoskeletal issues. We have points spleen 21, we have points gallbladder 22, gallbladder 23, and we're going to achieve some proprioceptive cueing from the acupuncture needles themselves. Now, these points are used if someone has rib side discomfort, if someone has, now this is the one that really gets me, trouble breathing. Why might they have trouble breathing? Probably because they're using the wrong stuff to do it, right? Some of these needles and the cueing is going to actually help keep things in check so that we can breathe more optimally. Now, these points can also help with motor impairment of the upper extremity. Again, why do you think that might be? Well, never mind the fact that there could be some scarring on the lateral walls of the thorax, but we're all about force transfer here. So in this junction of EAO and serratus, if they're not receiving signals, you're going to have some motor impairment. You're going to have some pain. You're going to have some weakness. Now throw into that equation some breath that's been disrupted, and you've got epoxy on top of that. That's going to hurt like all get out. So we really need to check movement as it cues with the breath for optimal functioning of the upper extremity and the lower extremity for that matter. One of my favorite things about this point here is that these points are said in classical Chinese medicine, traditional Chinese medicine, these points are said to help with pain in the entire body. And so somebody might look at that and go, that's just that acupuncturist talking. But it's not. We are improving our ability to transfer force with proprioception. So you actually can make an argument. We're talking about the interdigitation between serratus and EAO, and we see how far EAO is going down. EAO has communications to the lower extremity as well. And if it's all coming from this sort of really intricate compensation pattern that our body has created, and we just needle these areas to help them kind of get back on track, then we have improved the biomechanics of the body, and we have helped decrease inflammation in the body. We have helped stop pain because now we're using things for what they're meant to be doing rather than what we're asking them to do. And that is a huge deal when we're talking about pain management. These acupuncture points here, whoa baby, are they important. Don't forget them. Anybody had acupuncture? Anybody had these areas needled?
Oh, yeah.
Yeah? It feels so good.
Mm-hmm. After.
It feels so good.
Okay, we're going to close things out with something we introduced to you in ID Level 2, lower extremity concepts. And that's a very important muscle on the x-axis called iliacus. Note that I did not say iliopsoas, nor will you ever hear me say those terms. Why do I keep those two separated? Because they're separated. All right? Iliacus comes from the iliac fossa. That's this deep fossa here. I want you guys to feel that for yourselves, okay? Find that ASIS we found earlier with the obliques. And I want you to go past these obliques, and I want you to gently dig your hand underneath that, just medial and deep, and right? For we who sit a lot, we might feel this be a little tender. For we who have intra-abdominal pressure building problems, we may feel a little tender, right? Feel the other side, see if they're equal. Maybe, maybe not equal. This iliac fossa is pretty expanse. This muscle attaches to this area. Does psoas attach to this area? No. No. Where does psoas attach? T12 all the way down to L4, the body's intervertebral disc, completely bypasses, for the most part, the pelvis to co-insert with the iliacus, and we'll talk about that in a second. But no, they do not come from the same place up top, right? Making them very different. Thank you, Yichen. Thank you, Yichen. Yes, different. The iliacus also attaches to something the psoas doesn't. It attaches to this thing called the iliolumbar ligament. The quadratus lumborum also attaches to it. And so I did a makeshift one for you because Dr. Jake doesn't want to be dissected today. And it usually goes from L4 and L5 transverse processes. And it's coming down and around to insert onto the iliac crest here. And so this particular ligament, although extremely difficult to palpate unless you got a scalpel. Yeah. This particular ligament has a massive attachment for the anterior layer of thoracolumbar fascia. Now, what do we know about this deep layer of thoracolumbar fascia? What did we learn today with that? My girl right here, attached to the internal abdominal oblique. The intrinsic muscles, as Dr. Anna described, that are exhalation muscles, have to attach to that in order to be called intrinsic muscles. The only guys that get a pass are the diaphragm and pelvic floor because they're inhalation muscles. But the iliolumbar ligament is an attachment for iliacus and the anterior layer of thoracolumbar fascia. Does that make iliacus an intrinsic core muscle? No, because it itself doesn't attach to the anterior layer of thoracolumbar fascia. But man, does it attach to the ligament that does. Why do you think that's important? Yes, it's how intrinsics send things to the outside world, to the limb, to the lower extremity. Look at the size of Jake's lower extremity. It needs force, baby. This particular ligament is going to help us transmit it, and iliacus is attached to it because of that. Quadratus lumborum is attached to right above that because of that. It's helping us with hip mechanics relative to intrinsic core stability. So although iliacus is not an intrinsic core muscle, man, does it help receive the force as such. Why else does iliacus have a connection to the IAO? It's not just iliolumbar ligament. Wasn't there something else we talked about? Maybe a fascia? The iliopsoas fascia, that's right. So this muscle is covered on its external surface with the fascia that the conjoint tendon is partially attaching to. Again, helping us take the intrinsic stability that we build and send it to the extrinsic world. So we have two parts of iliacus that help us receive force transfer. And we have two opportunities for iliacus to now act as a core muscle when he's not. And I know that you know somebody, if not yourself, who's experienced this. Pinching pain that we were talking about earlier. Iliopsoas bursitis, right? Oh, iliopsoas tenosynovitis. Ah! Pinchy hip, right? Or the patients or clients that come to you and say, I'm just tight here all the time. It's just, oh my gosh, I feel like I can't get into my squat. I feel like I can't move. I feel pain during all types of activities because of tightness felt here. And when they do this, where do you go? Here? I hope not, rookie, right? Not after this discussion. You're going to go to internal abdominal oblique, right? That has all this relationship with it. Internal abdominal oblique and transversus abdominis because of the iliolumbar ligament and also the iliopsoas fascia. Now, iliacus can be phasic, right? Now, when he's phasic, he works on the x-axis and on the z-axis. Doesn't hugely participate on the y. He's so powerful on the x that he doesn't get a lot of chance to work on the y, and he's really crappy at the z. So the x-axis for us is going to be flexion and extension. Everybody do that for me for a second if you're in a good position. Flex your hip, and then extend your hip without extending your back. See if you can try that. Not an easy feat. So flex your hip, and then extend your hip. Iliacus, when he's short, helps you to flex the hip. He is by far your most powerful hip flexor. He's got a lot of help from everything from psoas, TFL, rectus femoris, the adductors. He's got a lot of help, but he is the big daddy because he's receiving all that intrinsic force from two different spots. Iliacus also can be a synergist with psoas for external rotation. So we can actually move your hip outwards. Now everybody try that. Pick up your hip in flexion and then do a little hey. External rotation of the femur. Can you guys feel it go short? And then to earn internal rotation, it has to go long on that axis. Now here's the fun thing. You can only be the king of one axis at a time. If you are king on the x-axis, you don't get to be on the y and z-axis as big force generators. That's just the rules of biomechanics. You guys ever tried to work 3 jobs before? How great were you at that? But if you work one job and do it really well, you're probably pretty good at it, and the other 2 you're pretty crappy at, right? I hope this is the one I'm good at, for your sake. Iliacus is the best on the x-axis of all his axes. Iliacus is your primary hip flexor, and a big problem for us if we don't have good intra-abdominal pressure because, okay, iliacus does have a similarity with psoas. Okay. What's its similarity? Do you guys know? What's its similar attachment? The lesser trochanter. This is a tough one to palpate. I'm going to show you how to palpate it here in a second. But the lesser trochanter is that guy there. Yeah? Pretty posterior. Greater trochanter, big dude out here. Lesser trochanter, more medial. So if we were finding our greater trochanters, let's do that. Everybody put your palm on your ASIS, okay? And then let your third digit just fall, and usually it'll fall at the bottom of the greater trochanter. Everybody feel that? You can rotate your hip to make sure you're on that bone. A lot of your external rotators attached to that, a couple of your internal rotators. Now, if you're at the bottom of the greater trochanter, you're going to be at the same line as the lesser trochanter. So you'll hook your index finger around your quads, you'll bend your knee, and then externally rotate. If you go deep to that rectus femoris, that big muscle, you'll come into an area called the femoral triangle. You'll be in the lateral floor of the femoral triangle, and that is the iliopsoas grouped tendon inserting onto the lesser trochanter. Can everybody feel that? Can you guys feel that muscle? Anybody feel tender there? Yeah. There's a bursa there. There's a fluid-filled sac right there. And also, there's this tendinous sheath here too. So you have dual protection against overuse of this. Now, why would the body be so stupid to put a bursa and a synovial sheath here? Is that a stupid mechanism? You have evolved to be perfect. You are perfect right here in front of me. My husband says this all the time, like, we're born perfect, we move through perfection, and you are doing that as we speak. So there's no mistake here, but why is it there? Bursae and synovial sheaths are there to prevent the bone from eroding. Why do we care about that? Well, bones are very gentle. They have a cortex on the outside, but the inside, what's the inside full of? Especially the femur. Marrow, blood, right? So we are protecting this lesser trochanter from erosion. And why would we be susceptible to erosion here? Why would we put two protective systems here, two different bursal systems here? Because we're bipedal, I'll believe that. We do a lot of hip flexion, but so do quadrupeds. Why? Why? Yes, because we had that iliolumbar attachment, right? Iliolumbar ligament attachment. Because we have this iliopsoas fascia attachment. Because your body knows you might be really crappy at building and maintaining intra-abdominal pressure. Why does the baby wait until about 4 months to finally kick its legs? Have you ever seen this? You guys have kids? The first 4 months, they are a snooze fest. They're so boring. They can't even make eye contact with you, right? You freak out at 3 months when they hold their head up. Oh, yay. And then at 4 or 5 months, they finally zoom in and start to kick that leg. Why do they wait 4 months to do it? What are they doing in that 4 months other than pooping and eating and crying? They're establishing intra-abdominal pressure and taking the pressure off the bursa. If this area is tight, can it then also be mobile? You can't ask iliacus to both stabilize you proximally and be a prime mover in hip flexion and external rotation. Monica, I can't tie you to that pole and then ask you to walk away from it. It's just not nice. We do this all the time to our iliacus. Maybe not the people in this room because you guys are very interested in human movement. But what about our clients and patients that sit at a desk all day? What are they doing? Dr. Jake, aka Captain Morgan. What are we doing to iliacus in this position? Shortening on what plane? X-axis. If I shorten iliacus on the x-axis and I keep it in this short binding position, when he then stands up to ambulate, what happens? Stay short. And do you see how that creates a cross mechanism of, okay, I got a problem now with my lower extremity, now I got a problem with force transfer from the bottom up. Because force doesn't just transfer from here down. It also comes from the ground up. So I created a stasis, a block here that Dr. Anna will tell you is loaded with acupuncture points in this femoral triangle. Well, there's not just acupuncture points. There's a gigantic artery, a gigantic vein, a gigantic nerve, the nerve that innervates iliacus. Anybody know what nerve innervates iliacus? It's the femoral nerve. The femoral nerve is L2 to L4, the lumbar spine, right? And that area is coming out from the back of you here. So you can see iliacus can even screw itself over with its overcontraction and steal its own innervation from itself by compressing these segments back here. That gapped, decompressed low back can allow iliacus to move freely. But let me ask you guys a question. If iliacus is in a short position, so we're putting Jake into a short position of pushing this into flexion, what happens to the hip in a fully flexed position? Compression. My Boris, is hip compression a good thing? Of course it is. Of course it is. During 2 phases of gait, right? Swing phase and suspension, right? When you guys do a lunge, is compression of your hip good? Of course it is. Yes. Beautiful compression, right? I'm going to do a lunge for you. Maybe Dr. Jake should. Dr. Jake, you're a very good lunger. Let's do it. Let me move these femurs. Yeah. Sagittal plane for iliacus. Go ahead and step forward for us. And let's do a little lunge. Do you guys see iliacus coming into a short position on what plane? Its most important plane, the x-axis, right? On the back leg, it's long on the x-axis, but short on the z-axis as external rotation, right? But we know he's not so great at external rotation. You got P-go-go-Q, the deep six in your butt cheeks to do external rotation, right? He's the king of x-axis. So yes, we want compression. Do we want compression on Jake's left leg? No. That's why to train a decompression of the hip or a stretch of iliacus, we put the knee down. This position is my work position. Anyone who sees me as a patient sees me work in this position all day. Why would I do that? I'm decompressing my hips. Because I know if I sit in a chair, it's going to compress the hell out of my hips all day. And although hip compression is good in certain phases, it's not so great in others. You want to be able to make sure you can do both. So yeah, you'll see me switch all day long and make sure I maintain this position. Also, for your clients and patients that have skipped this phase of development, which is the 11-month position of the baby, can you see how that develops hip problems for the person? How many started walking before 11 months? Me too. It sucks, right? This is why I spend all day in this, Melinda. I started walking at 9 months, and my parents were like, oh, how great is she? She's so advanced. No, I'm not. I'm a complete rookie. No, kick your kid down, right? Don't let them get out of this position. They need to develop the hip decompression and compression relative to each femur. And also what Dr. Anna was talking about, the connection of iliacus with the internal abdominal oblique and transversus abdominis. Dr. Jake, take a deep breath in this position. Oh, he just fills up like a balloon. If he's filling up like a balloon, what's happening to his left hip? It's decompressing. Iliacus is not being asked to hold tension for him. We're not going to ask iliacus to be tied to that pole and walk away. We're going to let it move freely within its range. So if I wanted to really maximize Dr. Jake's iliacus opening into a stretch position right now, what can I do on his left femur? I can slightly internally rotate, keep him in a full hip extended position. I'm going to take his arm up just because I know that there are those thoracolumbar attachments to the iliacus. I'm going to keep his neck long, chin tucked, chest wide, and ribs down to make sure he can maintain his gut pressure. Then I'm going to have him exhale as he projects forward. He's not going into his low back. This is not, how far can I extend my back day? This is keeping his abdomen in a good pressure so he can release the tension here. How many degrees of hip extension do you get? 10 to 30. 30 if you're lucky, right? Dr. Jake, I'm really sorry about this. If I push him into back extension, is he getting more? No. Now his back is moving more than his hip. His hip is now going to tighten worse to try to stabilize his lumbar spine, right? So I'm going to move him out of that position. I'm going to pull his ribs down, and I'm going to ask him just to move his hip forward. 10 to 30 degrees is all you get. There's not much motion there. But I want him to maximize the 30 that he's offered to eccentrically load this. Wouldn't this be a wonderful way to work? Wouldn't this be a wonderful thing to do to break the monotony of sitting at a desk? I see a lot of people with sit-to-stand desks. I think that's great. Is standing so great for this situ either? It's not so great. Because when people stand, sometimes they just stand like this in a short iliacus position in a hyperextended lumbar spine. So what would you tell that person to do to maximize their gut pressure and take the load off iliacus? You tell them to tuck their butt underneath them a little bit and open up their hips. You have them say, hey, pockets out, bro. Right? Then type. So iliacus, if you're trying to maximize his ability and importance and strength in a short position, you would train something like a lunge, right? Where the front leg can compress the hip, the back leg can decompress, and then switch it up. Have you guys ever treated a client that had a chronically compressed hip, just always in its socket? Some people call it a short leg. You guys hear that? Or constant hip hike? Yeah, you see that a lot, right? The iliacus can be very problematic for your patient in this chronically short position. Not only are they crappy at really true compression. If you're pathologically compressed, you don't compress well. And you also don't decompress. What do you think is the result of a chronically compressed and shortened iliacus, semi-shortened iliacus? What do you think is the consequence? Hip replacement. It's chronic compression. They don't compress well either. Just because they are in compression doesn't mean they do that well. And all of a sudden they're wearing away at their cartilage. They're developing iliopsoas bursitis, which is a warning sign for hip compression. Anybody had this warning sign before? I know I've had mine. I've had pinchy hips from squats and then restricted from back squat for 2 years now, and I have not missed it because I hated that feeling, and stuck in half kneeling for most of my day. And do you guys think I have hip pain? 0. And when you watch me, I'm not in a hip compressed position. Why is that? Because you got to earn it back, baby. You have to earn it back. And you have to understand why you're doing this. If you understand the anatomy, it works. We talked about femoral nerve, right? These guys are synergists to the quads. Iliacus, major synergist to things like sartorius, the quadricep group, and even his little brother pectineus. In this floor of the femoral triangle, we have a neurovascular bundle, right? And this particular tightness can shut off blood supply to the hip itself. The tighter the iliacus is, you're compressing an artery called the medial femoral circumflex artery that actually feeds the hip. So not only are you shutting down the motion of the hip, you're shutting down its blood supply, along with his brother pectineus. This is not good. The primary hip compressor is iliacus in the X-plane, and then you'll learn in level 2 a lot about pectineus, a muscle that also compresses the hip. The brother to this guy, they're right next to each other on the floor of the femoral triangle. So everybody feel this for yourself. If you're comfortable being on your knee, everybody take a knee and get your neck long, chin tuck, chest wide, ribs down. And then put your hand on your pocket, whichever pocket is the one with the knee down. And I want you to feel the 30 degrees of hip extension that you might be allowed. No back extension. The back does not move. Take a nice deep breath in. Make sure your back doesn't move, and then let that hip come forward. Let that front hip's iliacus compress in the x-axis. Let it decompress on the knee that's down on the x-axis. You guys feel that opening there? Oh, how wonderful is that? Such a great feeling. How many of your clients need this? So many. Start asking them questions about when they started to walk. If they started to walk before 11 months, they are prone to hip compression. They're going to be at risk for needing THR later in life if they don't fix it early in life. Teach them how to build strength and capacity in the intra-abdominal pressure so they can take pressure off iliacus. What's your primary thing when someone has a hip compression? Where do you start? Always. You're starting with the building of intra-abdominal pressure first, because IAO attaches to the anterior layer of fascia that attaches to the iliolumbar ligament. Because IAO and TVA, these intrinsic muscles, attach to the iliopsoas fascia. Because we know iliacus, if he's stabilizing for a loss here, he can't mobilize you, and therefore might get stuck in compression and might put your hip at risk for needing THR later. Or femoral acetabular impingement syndrome, which is really common diagnosis. Iliacus is not to be ignored. Understand it's different than psoas. Psoas, extrinsic core muscle. Iliacus, not. Psoas, coming from the thoracolumbar spine. Iliacus is not, come from iliac fossa. Psoas, no attachment to iliolumbar ligament. Iliacus does. What's the only damn thing they have in common? Lesser trochanter. And they do share a bursa and a synovial sheath. Are they innervated by the same thing? Nope. Iliacus, femoral nerve. Psoas, nerve to psoas major. I can't even make it up. It's called that. From different ventral rami levels a little bit higher. Not the same thing. So when you take a seminar and read all these things about how important it is to stretch the psoas, we'll tell you why in level 1 that you don't do that and why you focus on iliacus.
Could chronic shortness of the iliacus actually take the femur out of the socket?
It's not that it takes it completely out of socket, but changes the position triplanar-wise. If you're stuck in the x-axis, and you're actually, let me show you. If you're stuck in the x-axis here, can you see how that limits you anteriorly and then also gaps you too much posteriorly? Not only can this cause a capsular issue posteriorly, but it really pinches the bursae up front, creating a possible impingement and limiting your triplanar movement. You're right about it being sort of, I guess, out of socket posteriorly and then cramped too much anteriorly and limiting your range of motion in all three planes because you do that. Okay, folks, are we ready to put it all together? Yeah? Okay, so I want you guys to tell me if I put my left leg back and right leg forward. All right, let's do this together. How do I make my internal abdominal oblique short on the y-axis and the z-axis? If I want to do y-axis, what is it? Right lateral flexion. Good. And what about the z-axis? Right rotation. Fantastic. On the left side of me, who's shortening with it as I go into right rotation? External oblique. See that on Dr. Jake? The external abdominal oblique is rotating me to the right on the left side here. Left EAO rotates me to the right. How about the internal abdominal oblique on this side? It's rotating me to the right. I have a little bit of lateral flexion because I'm hiked up a little bit in this hip. Okay. What about my serratus anterior connecting the EAO? Is he long or short as my arm goes forward? Short. So can I see how the serratus anterior is shortening with the same side EAO, which is shortening with the internal abdominal oblique on the opposite side? Very good. What about my iliacus that connects to my IAO here on the right side? Short on the X. Very good, Monica. Short on the X-axis. This is what we do all day long in gait, hopefully. So I want you to come out of it. I want you to feel that. So step forward and feel all of those shorten together. Awesome. Then come out of it. Now do the other side. And feel the left EAO go on stretch, the right IAO go on stretch, the serratus anterior go on stretch as you do the opposite. Now that's a mind blower. And now the other side, EAO on the right is short, your left IAO is short, your left iliacus. What's happening to your right iliacus? Lengthening too. So at any given moment on the sagittal plane gait movement, you're having to work these muscles in synergy. And if something's thrown off, it affects the whole system. Is a shoulder problem an opposite leg problem? You betcha. Is a shoulder problem a gut issue for building pressure? Yes. Is a right shoulder problem a left shoulder problem? Every time. Your patients will think you're crazy at first. They'll say, Doc, why do you treat my left shoulder if I have a right shoulder problem? Because they move together. They do all day long. You think walking's not complicated? You took 12 months if you knew it was good for you to do it. And you had nothing else to do. Poop, pee, cry. You didn't pay taxes. You didn't go to work. It took you a long time to develop that. Now sometimes you may have to earn it back because life hits you with those curveballs. You have to learn your mechanics again. Now, that's not just true in this action. How about a lunge? Who likes to lunge? Who likes to take stairs? Yes, baby. Let's do a lunge. Okay, let's prove this true too. Everybody step forward with their right foot. Come down to the left knee. Who's short on the right that we discussed in this hip? Iliacus. How about here? Internal abdominal oblique. Left side for rotation. External abdominal oblique rotating us this way. Yeah? Hopefully serratus semi going onto a short position. And then pop up again. Good. Now step back to the opposite side and do your reverse lunge. Do you see how all those same structures just went on stretch? So hopefully you'll start to think about both eccentric load and concentric contraction. That you're always constantly, maniacally thinking about who's short and who's long. Why did Dr. Anna say the long position is so important? So you can actually get a better full contraction. So if someone is stuck in hip compression, do they need to learn how to compress their hip? Yes. They have to learn how to do it safely. What would you do to them first? Decompress them and then take them into that next position. We have to meet them where they're at, then take them where they're not, then take them back into a healthy position. Please consider this when you're looking at things like the lunge, when you're looking at things like gait. Think of who is long and who is short, who might be affecting the other side. We don't move in a pattern where it's just half of us moving. We're always moving with both parts. We're always accommodating. Yes, we are largely symmetrical, but there are some asymmetries. And if your client walks in with an asymmetry already, you have to meet them where they're at, then take them where they're not. Do we have any questions before we leave, you guys? Do the upper and lower fibers of serratus anterior have separate innervations? Well, think of it like this. If you come from the long thoracic nerve, you're from C5, C6, and C7. So therefore, those ventral rami are going to those various myoneural junctions, meaning you came from 3 embryonic centers called somites. Serratus anterior doesn't exist, Eric. It's migrant myotomes, right? I know. We do that to make us feel comfortable because, we see this muscle, and therefore it is external abdominal oblique or serratus anterior. My quick answer to you is that's complicated. Most of the C5 innervated fibers are going to be more superior. C6 a little bit lower, C7 a little lower. And the lower fibers of serratus anterior are force coupled with the upper trap and lower trap for the most part. The upper fibers of serratus are right there where the rhomboid and the levator attach, right? So they're going to be a force couple for downward rotation. So it's less about what innervates it and a little bit more about where it's located. Now, I will say that the levator, scapula, and rhomboids receive their major innervation from C4, C5. So the C5 part of serratus, the upper part, is going to move more with them, right? Where the lower part moves more with the lower trap. But to be honest with you, it's a heavy discussion, but it's more about the positioning rather than specifically the innervation. But I like the way you're thinking. My kind of people. ID is a good start. Look at the anatomy. Don't be afraid of it. You guys were just able to shout out all that stuff to me. Would you be able to do that before these 2 hours? Maybe, maybe not. But you seem pretty confident now. And that was 2 hours. That was it. If you commit to learning the anatomy in this way, it's a whole new world. You get obsessed with watching people walk at the mall or walking down the road. Then you look like that creep show that's watching everybody walk. Just don't make eye contact. And then you start to look at this, and I swear that you can learn it if you put it in your body. You learn how to palpate. Don't look at something like the pubic tubercle and say, I don't know where that is. Whoop, guess it's not important. Of course it's important. Start to think about how these things interconnect, and I swear to you, we are completely devoted to making sure you know it. If you decide to take an immaculate dissection course with us, you get a lot of this times 100. Plus, we give you Vimeos of everything. Plus, we give you a lot of our time to be able to cover all the questions, a gorgeous manual. But more importantly, we want you to put this into your body and feel it for yourself, and then come to us with your questions. Don't be afraid to take your anatomy knowledge to the next level. And don't let anatomy freak you out. It's not that freaky. You just got to take it muscle by muscle, step by step, and really learn why these things are interconnected. Muscles don't really exist. We make that up. They just migrate from myotomes to their spots and attach to bones from these things called sclerotomes. They don't really exist. So take the pressure off and feel what this stuff is supposed to do. And you might find yourself to become an even better diagnostician, a better trainer, a better understanding of the way your own personal body moves. You were given this huge gift, this body. And we hope that you take back what was taken from you in your development and even progress yourself to a position that you weren't even able to earn a year ago. If you don't have a pull-up, earn it. If you can't exhale for 30 seconds, earn it. And hopefully we can help you along the way. Dr. Anna, do you have anything to add as far as what you would like to leave them with?
So that everyone's clear, immaculate dissection 1 is core concepts. Immaculate dissection 2 is lower extremity. 3 is upper extremity. We don't require them to be taken in order because so much of it builds off of each other regardless of what order you take it in. You know, we've already discussed here in the past 2 hours how the upper extremity is connected to the core, how the lower extremity is connected to the core. So you're going to hear a lot of things that really sort of solidify everything that you learned in previous courses. And we're going to look at, you know, Dr. Julie said the interconnectedness of all of this. That's the sort of recurrent theme throughout the entire manual. And you have that. And you do have it forever. You have the Vimeos. You have Facebook groups that you can actually get on. And if you say, hey, I was looking at this and I don't exactly remember why we did this or why we talked about it, or I've got a client, I've got a patient who's presenting in this way. Put it on the Facebook group. And we've got people all over the world who have joined this and they're ready to jump in there and learn from your question and put in really valuable input. It's a way that we're all kind of refining our system of diagnostics together. And we're really helping each other solidify the understanding of all of this. And we're improving each other's biomechanics. It's a really incredible network of people. We've just had the most fascinating people come to these lectures. People of all different backgrounds, people who've had anatomy, people who have had not so much anatomy, people who have finance jobs during the day. And then they come to this because they want to know about their bodies. And it's great, and everyone's got valuable input. And so there's just really not a better way to connect to what everybody's talking about. And just this is a really great dialogue to be a part of.
It really is from every background. It shocks the heck out of us.
Yeah.
We've had everyone from artists to yoga instructors, Pilates instructors, who are phenomenal, by the way. I had no idea about Pilates until holy cow, do they know anatomy? Physical therapists, osteopaths, medical doctors, prolotherapists, chiropractors,
Equine therapists.
Equine therapists. We had an equine therapist, like a horses, dentist. Yeah, we had an amazing dentist come to see us. And we weren't even talking about the mouth. It was great. We planned also to build more courses for you. You want something, we give it to you. We have ID4 coming up in 2017, which is peripheral neuropathies, impingement sites for nerves. We're building course for head and face and hands and feet and all kinds of different parts of the body so you can have a better understanding of how things are put together. And if the course doesn't exist, you tell us. We create it for you. We are part of your network of learning. And nowhere is it written that you have to take an anatomy course before this. Just come, learn, dive in, be freaked out, be overwhelmed by it. Fine. We're all overwhelmed by anatomy. Come be overwhelmed with us and push yourself to the next level of understanding what this anatomy means. Well, I guess this is where we thank you. Thank you so much for your Friday night. Oh my gosh. We love this stuff so much. We're major anatomy nerds. We can't believe that even our moms like our Facebook posts, let alone you guys. Thank you so much for being involved with tonight's filming. We can't wait to share this more with the world. We've been on 4 continents now in our first 2 years. It's blown our mind how people are interested in it, and we really want you guys to learn anatomy. Huge thank you to Catalyst Sport for hosting us tonight. We're all clinicians here and very proud to be here and proud to see immaculate dissection concepts at work on the floor. And hopefully we'll get to see it work even more around the world as you guys utilize these tools and take it to the next level. Special huge thank you to Jonathan Fernandez and Danny Quirk, of course, the king of all anatomy. His drawings continue to blow our mind. We never get sick of it. If you want to see more, please come to one of our seminars. You can find us at www.immaculateDissection.com. You can like us on Facebook. We'll be there too. And hopefully we'll see you at a seminar soon. Thank you so much for coming. Thank you. Thank you.
Thank you.